there before the care program?
Yeah, yep, for about 6 years.
Oh, wow.
Sempervirens, the crisis unit, mobile response, kind of anything crisis realm. That was me.
So this has been your realm
Yeah.
for quite a while
Yep.
now.
Yep.
And how long have you been with the care program for Eureka?
I hired on August 1st. And so, the first couple months there were program development, and then we actually kind of soft launched in January with the hiring of our first case managers.
January. Okay, so 2 months under your belt now.
Yeah. Yep.
How do you feel like it's going?
So far, so good. I mean, more work than we can keep up with the current staff, and so the goal is to keep sorting out funding and getting more staff and just kind of ramping things up. And yeah,
Seeing how everything goes.
exactly. Yep.
How do you I guess we should lay out what was the need for the care program in Eureka? What sparked the desire to start that?
Yeah, I think there's a real need in getting folks from point A to point B as far as services go. Services in Humboldt, there are a lot of agencies doing really passionate work and doing it really well, and it's just sometimes difficult, even for like care providers, to figure out which agency is going to be the most appropriate to go to, or how to, navigate getting a client from, say they're at Open Door and they need to go to Social Security to, reestablish or get their ID, or not their ID at Social Security, get their Social Security card. And then from there, they need to go, back to Open Door, but then they also need to go to a pain referral, or they need to, then get mental health treatment, and they need to, go over to behavioral health. And then that's 2 appointments to get in for a doctor there. And, it's difficult to navigate a lot of that, even for folks who are doing really well. Much less if all of a sudden you have some sort of impairment, like, you're hearing auditory hallucinations, or, you have profound depression and your motivation is tanked and you don't want to get out of bed in the morning. Um, and so, for folks who enter crisis, they come out of that crisis, we have some services that help with that. We have the crisis unit, folks can, if it's to the point where they need to be on a hold, they can be on a hold and go to the hospital and they can get services. But when they come out of that, sometimes there isn't always the follow-up available. Sometimes it's not easy. Maybe they don't fit, the box that, each agency needs them to fit into for their funding sources or whatever. And so just seeing that, needing more crisis services in the community, combined with like needing case managers that can help folks get from point A to point B, really, I think there's a series of gaps that folks were falling through as a result of that. And so, through the city and a lot of work from Commander LaFrance and Jeff Davis, who's the program manager for Uplift Eureka, they really worked hard to kind of pave a landing pad for a mental health program, and here we are.
Yeah, I mean, it seems like there's a lot of hoops to jump through, even if everything was going well for you.
Oh,
And then
absolutely.
to stack on if you're homeless or if you're experiencing drug abuse or mental health, to try to go through all that and deal with one agency and then get bounced to the next agency. And then it would just be a lot to traverse.
It is. And, there's the unfortunate thing too, where a lot of substance use and mental health are often differentiated. And, in the broad scheme of things, I mean, they're all health issues, right? And, we've come a long ways in society in knowing that, substance use isn't a moral choice, it's a disease, and there's a biological correlate, and, you actually have effects in the brain that change as a result of the substance use that cause you to crave the substance more. Um, and yet, there's a lot of services though where, if you have too many mental health issues, you can't get substance use treatment. But if you have too many substance use issues, you can't get mental health treatment. And so like, how do you navigate that? Right. And so, working each agency at the same time, trying to, get some sort of detox, and then trying to get, mental health medications, or getting some sort of mental health services or counseling or whatever. And then, get into maybe a rehab at the same time. I mean, that takes a tremendous amount of coordination. And, for someone who, maybe they're homeless, maybe they, have a series of impairments, they don't have a phone, that, I mean, that's, a near impossible task for them to accomplish on their own. And then, couple that with, uh, some of the insurance barriers, if you don't meet the right medical necessity, you don't necessarily get a case manager assigned to you. And, so maybe the places that you're going to, they have case management, but you don't qualify for it. And so then, folks like that end up falling through the cracks, and they end up having to wait until it's become a crisis for them to, get looped back into services, which is rough.
Is that a significant problem that there's not enough intervention before it reaches this boiling point?
Absolutely. I think, the goals that we're really trying for are to go further upstream for preventative care, combined with then also still trying to provide more crisis intervention in the community. And so, I mean, it's trying to kind of handle things where we're at right now, but then also develop, the resources and the foundation to be able to go further upstream and stop some of this stuff from happening in the first place. And that's a real challenge for the field. I mean, that's a challenge that we're facing nationally with mental health issues and substance use issues. Um, we're we have an intervention based healthcare system where we wait for things to occur before we intervene. And it's been a real challenge even for like the medical side of things, like the physical health side of things, to really push preventative care. um, and it's even more of a struggle in mental health care. We're at least at a point where most of us, who have access to a primary care physician, go and get a checkup once a year. Most folks are not checking in with a psychiatrist or a therapist, once a year to kind of see, how things are going when they're having a hard time.
And then, I mean, preventative care across the board, like you said, is just the foundation for it is not there. Where
Absolutely.
everyone just waits to show symptoms, and then okay, we're going to treat the symptoms, but we're not getting at the root cause of what is causing these symptoms, what's going on here.
Right.
And especially with mental health, like you said, nobody's going to a psychiatrist unless you are struggling and it's apparent that you need to go seek some outside counsel and get some help. And
Right. Right.
if that's not showing, what do? You just go about your life.
Yeah. Well, and you couple that with for individuals who are experiencing things like bipolar disorder or schizophrenia. One of the symptoms, one of the core symptoms, is something called anosognosia. And what anosognosia is the uh, symptomatic lack of insight. So it's not just that you don't understand that you may be sick, or that you don't understand that like things are getting bad or this behavior is odd. It's that as a result of the illness, you've literally lost the capacity to kind of step back from yourself and look at a situation and go, "Oh, what I did was just kind of weird," right? I mean, like if you or I were to, rip our clothes off and go walking down the street naked and, shouting about being God, it, in our right minds right now, we would think of that and go, that's not in line with society's expectations, right? For someone who has bipolar disorder, who has schizophrenia, that sort of thing may happen, but as a result of the illness, they literally lack the capacity to look at that situation objectively from like an outside space and recognize that this is unusual. There's something about this that is not going well, or is that's kind of uh, problematic for integrating into society, right? And so that's the extreme version. That can even come down to whether or not they acknowledge that they're sick or that they need to take medications, right? I mean, if you have anosognosia and you don't believe that you're ill, why would you comply with any sort of treatment? And so there's not enough education around that in I think just the general public, that part of these illnesses is a lack of insight. Is that some of these folks who we see out on the streets who are struggling with this stuff are struggling with something that impairs their ability to recognize that they're in trouble. It impairs their ability to recognize that they're sick. And so a lot of that frustration, well, why doesn't this person just get, treatment or go to rehab, or, go and, take their mental health meds? Well, they may not understand. They may not have the capacity to understand.
How do you implement preventative care for those folks then? If they're not aware of it, are you just relying on maybe family members that could see the red flags, or does it just have to hit that point where it's apparent to society?
I think family members definitely are a piece of it. If family is still involved, really engaging that family support is super, super important, making sure that they're integrated into that person's treatment. So like if that person's having therapy, making sure the family's involved in that therapy so that the family can understand what's going on just as well as the person. Um, when folks like that are already sick to the point where they're experiencing that symptom, oftentimes it unfortunately becomes this place where we have to wait for that crisis to happen. And then they receive some sort of involuntary hospitalization, or they receive some sort of involuntary treatment. And the hope is that once that involuntary treatment happens, when the symptoms get better, because that is a symptom, then that reduces and they're able to get some of that insight. That's kind of the time to really strike and make sure that they have good therapy, make sure that they have good treatment, and that they're plugged into services so that they can understand and practice while they're doing well that, this is something that I need, and that helps. And then, yeah, plugging in their social supports or, friends, family, a good therapist that's going to see them regularly. And then, really practicing like gaining that insight or how to reality test or, picking out very early symptoms that are not anosognosia, when maybe an episode is coming on, and then, treating that at that moment when those early symptoms are coming instead of, it
Down
getting
the
to the
road.
point, right, where they lose that insight and things get bad again.
What percentage of people with bipolar with schizophrenia have what is it? Anosognosia?
Anosognosia, yeah, Anosognosia. I don't know the percentage offhand.
Is it pretty significant?
It's pretty significant in a fair amount of folks, especially in I mean, I can't even really say anecdotal because my anecdotal experience is skewed because I work with a lot of the folks who were in the hospital, right? And some of these are the folks who the crisis has happened, things got to the point where it was bad, and so we saw a lot of folks with anosognosia working in the hospital. Um, I mean, it's a not insignificant amount. There is a lot of research out there. I don't remember the percentage offhand.
And I would imagine for those people that do have that, there's really only one path, and it leads to a service like yours. Because, I
Yeah,
mean, can they function regularly through society enough where they wouldn't end up in a mental health facility? Like, it
I think
wouldn't be bad enough to get to the extreme, or is that just a guarantee if you have that?
it depends. It depends on the other symptoms that come with that, and the support networks that that person has. For some folks, they're able to cope with stuff. They're able to, maybe they hear voices occasionally, but they're through whatever system they have set up to cope with that, they're able to work with it. There are a lot of folks who are able to wrangle the energy that comes with mania and make it somewhat productive. It's suspected that a lot of like famous artists had some degree of bipolar disorder, whether it's bipolar one or a lighter version bipolar two, and hence why they have like depressed periods in their paintings, and then they have more up periods in their paintings, right? And it's expected that there may be a component. I think Van Gogh comes to mind with that. Um, and so there are ways to survive with that, and that's an important piece I think to factor in, is that with the right support and with the right tools and coping skills and education, these illnesses don't have to be crippling. Folks can be with, again, with those all those supports, they can get better, and they can live a relatively normal life with the hoops to jump through to make sure that you self-care, just as anyone who has any other long-term illness. I mean, for folks who have diabetes, they have, if they want to treat themselves well and not be impaired by that diabetes, they have dietary hoops that they have to jump through. Heart disease is the same thing. um, Arthritis, mobility issues, right? I mean, there's all sorts of long term stuff that folks have, impairment, but that impairment can be minimized with the right care and with the right self care and services in place. Um, I think it's again, maybe because mental health is more stigmatized and uh, in the sense of like preventative care, lags behind physical health a little bit more. It's maybe a little more difficult to get those things in place.
Well, and again, the key being support and care.
Right.
You have to take these steps to help yourself, and it helps to have a support network around you.
Absolutely.
And how many
Yeah.
of these people, when they're going down that path or are deep into it, have that network and have the ability to care for themselves in a functional way, in a productive way?
Yeah, and I mean that's tough, right? And it's even more difficult too about the time that substances become involved, because then some of the behaviors become pretty abrasive to family members, to friends, and some of the behaviors end up kind of pushing their social supports and familial supports away. And then as a result, when things are at that crisis level, there aren't those supports to engage, which is really awful. And it becomes this kind of downward spiral where the symptoms push folks away, but then folks pushing, being pushed away actually makes the symptoms worse. um, and it's difficult, and some folks don't have it. I mean, some folks just don't, and that often results in more inpatient admissions because they don't have those supports. So when they spiral hard, and it becomes point where it's a crisis and they end up, detained on a psychiatric hold, and um, it's a rough situation.
Are drugs fairly intertwined in the mental health story?
I think drugs are often intertwined in the mental health story. I mean, if we go back to the beginning of humankind, right? I mean, we've been trying to alter our brains and get high since we
The
figured out we
beginning.
could, right? I mean, there's evidence thousands of years ago that we are chewing on cacao leaves, or there's another plant in um, the Asian continent that people are able to kind of get an altered mental status, so to speak. Um, and I think as we've evolved and progressed in society, we've just gotten more and more creative and more effective at getting higher or adjusting our brain. And so I think it's pretty common when folks are uncomfortable, they're going to seek some way to adjust that. They're going to seek some way to cope or alter their mind. And whether that's the person who is newly homeless and is scared to fall asleep at night, and so someone offers them some methamphetamines and they use meth to stay up so that they can sleep during the day so that they don't get robbed at night, or whether that's the person who has profound anxiety and uses cannabis to reduce that anxiety, but in the long term cannabis can exacerbate anxiety by decreasing natural coping skills. So it's similar to, I guess, in the sense that, medications, right? If we look at drugs versus medications, I mean, all of them are substances we're using to adjust chemically. Some things are better than others, obviously. Um, but if folks don't have access to the right medications, it's not uncommon for them to seek some other mind altering substance to cope.
You mentioned meth to
Hmm.
stay awake so you don't get robbed at night.
Hmm.
Is a lot of the drug use, I guess, would you say need based in a sense like that? Or is it more so escapism to try to get away with that or treat your symptoms with
Yeah,
whatever you can get your hands on?
I would say all of the above. I think some combination of that, and I mean, need based. I think sometimes that escapism is needed, right? I mean,
Yeah, it depends
you
what
know,
you define need
if
based as.
if you're in significant pain and you want to zone out and watch TV, then I mean that's need based at that point, right? And so if the methamphetamines are, for a lot of folks right now with the fentanyl epidemic, that's kind of doubling on top of the opiate epidemic. I mean, it's a lot. I think for a lot of those putting ourselves in their shoes, they see it very much as need based, that they for whatever reason cannot cope without that substance. Um, I don't think anyone, and I mean, this is, I think, leftover remnants of when we very much saw substance use as a moral dilemma, right? It was good or bad, and if you did drugs, you were bad. Um, and it's not, right. I mean, we know, again, we know there are the biological correlates. We know that there's an addiction component in genetics and all that. And so I think when you look at individuals who are uncomfortable, no one wants to use a substance that's going to make them worse, right? I mean, objectively speaking, if you can offer someone a solution, two solutions, one that has minimal side effects or no effects at all, and one that is really awful, and you tell them it's gonna be neurotoxic, it's gonna cause cell death in your brain, it's gonna cause teeth decay and all these other health issues. Everyone's going to choose the one that doesn't have the issues, right? But if that one isn't available and folks are still uncomfortable, then they're in a position where they have to choose, well, do I cope with my current discomfort, or do I use this substance that I know will hurt me? And, that may not be so much of a conscious choice for a lot of folks, but it's a choice that is made nonetheless. Um, there's even like mice studies that this is supported in, where if, they had like two, oh, how did it go? They had one cage of mice where, or maybe been rats, mice, whatever. The rats were in a cage. The cage was too small. They kind of overpopulated the cage, right? So the size of the cage did not meet the capacity that was realistically needed. And then they also, in the smaller cage, doubled the gender ratio. So there are two males for every one female in that cage. And then they did two bottles of water, two sources of water, one that had opiates laced in it, and one that was just regular water. And when you had the small cage with the skewed gender ratio, the mice disproportionately chose the opiate laced water. when you doubled the size of that cage, right, made it appropriate to the population and equaled out the gender ratio, they disproportionately chose the regular water. And that's, their basic needs were met, so there was a lot less push to go and drink something that, has some other altering effect.
It's telling. It kinda
Yeah.
makes you worry about urban cities, like
Yeah.
huge, dense populations of people stuck in this small area and where that leads. It's like, well,
Yeah.
if you look at the mice, what does that say?
In society in general, right? I mean, there are so many folks who just don't have their basic needs met. I mean, whether it's, because they're tightly bundled in a city or whether it's because they just don't have enough money to get by or, in California, we look at like the housing crisis with, how unaffordable housing is and, how many folks we have that don't have housing in the first place and there isn't enough shelter. I mean, when people's basic needs aren't met, they're 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 going to seek other things to fill that need.
Do you give any weight to the idea? I mean, one of the big arguments with the homeless is there are people in the camp that think you should treat the homelessness first and then the addiction second. And there are others who think that needs to be reversed. You can't just house them and then worry about the drugs. You have to stop the drug use so that they can function and then you house them. What is your stance on that?
Um, I think that it's kind of a false choice. So, I mean, the it has to be all at once, right? So there's the housing first model, and the housing first model says that the true housing first model, not what some folks will say. The true housing first model is you get folks housing because if you do a bunch of work with sobriety or you get them into rehab and then they get out of rehab and they don't have housing, they go back to the streets, they're going to relapse. If you get them mental health treatment, they get mental health treatment, they stabilize, they go out to the streets, they're going to decompensate. Um, so you have to have housing in there, right? That has to be a piece of it. And it has to be the first piece of it because again, if you do these other things, you're spinning wheels. But housing first is not housing first in the sense that it's housing first and then you don't do anything, right? I mean, you have to have mental health and substance use treatment. You also have to have, uh, some sort of therapy or job coaching or something to give meaning to life, right? I mean, if folks aren't engaged in something, they're not stimulated, they're not working, they don't have some goal to be at, some routine to establish, um, they're going to spin and fall back on old coping habits, right? They're not distracted, they're not engaged, and it doesn't give them a whole lot of reason to do that if they don't have some meaning to achieve. Um, I think the concern is that a lot of housing first, it's housing first, but then it's also kind of housing last, and that they house folks and that's it. They don't get the services they need afterwards. And in those situations, you end up having folks either burn out of housing because they do something inappropriate and it gets to the point where the housing unit can't take them anymore. And so then they're thrown out. Or they're housed and, they're just off the streets and having, just as miserable a time suffering in a house instead of, where at least folks are seeing them amongst community. Right. I mean, that was a huge issue with like the fentanyl epidemic right now, right? I mean, we saw this phenomenon where when the COVID pandemic hit, we got all these folks off the streets and into motels. Well, what we saw after that is a skyrocket in opioid deaths and overdose rates in general. And that's because, folks went from using together, where if someone sees someone overdosing, they can administer Narcan and reverse that overdose, to now people are using alone in a motel room. And so when they overdose, they die. And so, it's not to say it wasn't right to get them off the streets. They needed to be off the streets, right? I mean, it had to be done. Um, but that's an example of kind of why we need to continue having that follow-up care. There were places that did it really well where they established like networks. Forget the name of the place. There's a place in San Francisco that had, they essentially established almost like dorms where they had like RAs effectively that were residents, and they had some sort of pay in return for their services, and decrease rent or something like that. But they checked on folks, and if someone was going to use, then they let the RA know, and the RA could check on them, and they found that that markedly decreased opioid deaths because there was at least that community established. What we found in the places where we got folks inside and out of COVID was that the opioid death rates went up because people just passed away alone in their motel room, which is tragic.
The fentanyl story is huge right now.
Yeah.
I was reading before you shut up, I was reading an article, I think from last December, and EPD was saying that a majority of the overdoses in Eureka were fentanyl
Yeah.
caused,
Yep.
which, I mean, it seems like,
State and nationwide, actually. Yeah.
yeah, I would agree with that too. It's just, I mean, how do you stop the fentanyl? How do you combat that?
Yeah.
I mean, that's the problem that's plaguing everyone right now. Nobody has any good solutions. We're stopping it at the border, but we're only getting a fraction of what's actually coming into the country.
Well, and it's difficult, right? I mean, I hate to say it this way, but I mean, heck, the silver lining to heroin was that someone at least had to be importing opium and someone had to be growing poppies in some field somewhere, right? I mean, there is a huge infrastructure that was needed for that, and fentanyl could just be created in a lab. Um, and it's a lot smaller and easier to smuggle. And so, I mean, you have this issue where, yeah, it's a lot harder to regulate, it's a lot harder to stop and track. Um, and yeah, I, certainly don't pretend to have a solution to that. What I can say as far as harm reduction is everybody, you, me, everyone, should have Narcan, and get trained for that. Public health will give it out for free. They will train you for free. The training's like 30 minutes. Um, California's actually passed laws to where you can't be held liable for administering Narcan to someone you see who's down and possibly overdosing. There's no negative side effect to the medication. And it literally goes into the brain. The medication goes into the brain through the nose and kicks the opioid uh, off of the opioid receptor on the brain and buys them like 15, 20 minutes before it rebinds. And so in that time, EMTs can get there. They'll probably add more Narcan, and they can get to a hospital and they can save this person's life. But otherwise, if without that Narcan, they stop breathing and they pass.
That's kind of a
Um,
scary thought
yeah,
because it means that things have gotten so bad. Now they're just pushing everyone to carry Narcan.
yeah,
That, oh, even if you use it, we're not going to sue you. You just do it.
right.
We need people to do that.
Yeah, I mean it's on the level of basic first aid, right? I mean it's
But I think you could
how
still
do you
get
tourniquet
sued
someone? How do
for
yeah?
CPR, right? If you give somebody CPR and you
There
mess
there
them up, I think you're still
there are
held
some
liable.
protections if I mean unless there's some proof that it's malicious, there are protections. If you see someone who's down and who's not breathing and you go and start rendering CPR and you do it correctly and probably end up breaking their ribs as a result, they there are some protections that you can't get sued. I forget. I think it's like the Good Samaritan laws, something along those lines, where if you respond in an emergency capacity out of good faith, then
You're going to be okay.
your ability to be held liable is very difficult at that point. Um, and so and Narcan's the same way. I mean the public health departments essentially see it as equivalent to providing CPR or providing rescue breathing to somebody. I mean if you see an emergency and you choose to go in and engage and save that person's life, they're gonna give you a helping hand in not being held liable.
I didn't know that Narcan wasn't a permanent fix. I didn't know that it'll rebind after a certain amount of time.
Yeah, and what we're seeing with fentanyl is people are needing multiple doses of Narcan, right? And so we're needing more and more doses to actually cause that effect where it kicks the fentanyl off of the opioid receptor
Does that
in
mean
the
that the
brain.
fentanyl's getting stronger?
It just means fentanyl has a higher, without going into a full neuroscience lesson, there's something called affinity, and fentanyl just has a higher affinity to those receptors. And so with that, it effectively binds harder. Not so much that the fentanyl is stronger. I mean, fentanyl is way stronger than heroin ever was. And I mean, there's a reason it was previously only given in hospitals, really, and that's because it is so incredibly strong. Um, and so the Narcan has to work a little harder to do that. But yeah, Narcan is definitely I mean, there's a time limit as to when the body then metabolizes that medication, and just like the opioids are metabolized as well. Um, and sometimes it has to be readministered. Yeah.
And you can re-administer it to draw out that length before
Yeah, I mean
EMTs or paramedics get
in,
there.
in talking with some of my paramedic friends who work in more rural areas, I mean, sometimes they would have to do, if the hospital's an hour and a half away, they may have to re-administer Narcan, every 20 to 30 minutes until they can get someone to that hospital, depending on how much opioids they used and how fast it's metabolizing. Because it may start to get off, and so then they see the person start to nod back out. You reapply. Yeah.
That's so crazy. Can you Narcan That's so crazy. If you repeatedly use Narcan, is the person, when the effects of the Narcan wear off, are they getting high again, or would they just knock out because it's an overdose? What does that translate
If
to
effectively they're
symptom-wise?
getting high again. So I mean, when you look at how say fentanyl works, right? Fentanyl, people use fentanyl. Fentanyl, the molecule binds to the opioid receptor in the brain, and then at that point, the individual is intoxicated. They're high, right? When you start to bind too much fentanyl to the brain, it starts to bind to the receptors that control breathing. You start to not breathe, right? That's the problem with opioids. That's how people pass. Um, so then when you introduce Narcan into that, it kicks the fentanyl molecule off of the receptor and replaces it and blocks that receptor from being utilized, right? So now that fentanyl is still in the bloodstream, it's just not binded to the receptor. So it's not depressing breathing anymore. Effectively, then when that Narcan is metabolized, if there's still fentanyl in the system, it will then rebind to those opioid receptors and, people will become intoxicated again or possibly overdosing again. Yeah.
Are most people that are ODing off of fentanyl, are they using strictly fentanyl, or is it laced in whatever other drug they're using? Because I've always heard that with cocaine, that you shouldn't use cocaine because it's probably laced with fentanyl right now.
I mean, everything's laced with fentanyl right now. There are cases of cannabis being laced with fentanyl, and so I mean, if you're going to buy weed, go to a dispensary.
They're lacing
um,
cannabis with fentanyl
yeah,
just to increase the weight or
I don't
the
know.
potency, quote unquote.
I have no idea. I mean, that's
That's a scary thought.
it is a scary thought, and that's for especially a lot of our houseless folks. That's a scary piece of being out on the streets and using substances is because I mean, you don't know what it's in. I mean, there are cases of kids accidentally getting into something that has fentanyl in it and them overdosing. I mean, some school districts are starting to train teachers on Narcan because, on the off chance, someone uses something at school and they don't know what it is and it happens to have, fentanyl in it and that kid overdoses, they want to be able to save a life. Um, yeah, it's scary stuff.
And a lot of it is the laced aspect that's coming into
It's a
play.
component. I don't know exactly like how much of this is a situation where it's laced versus people just using fentanyl to use fentanyl. Um, but I mean, it's definitely a scary component. I mean, whether it's in methamphetamines or whether it's in cocaine or whether it's in cannabis. I mean, it's out there.
I don't know what you do about that. And I don't understand the incentive to lace everything with fentanyl. I mean, if you're looking at it from a business standpoint, which is kind of not necessarily great to do, why would you want to kill off your clientele? Why would that make sense to put this drug? Because it only takes a incredibly small
Yeah,
amount to overdose on fentanyl.
right. I don't understand it. I mean, for folks who are seeking if their perspective is I want a quote unquote better high. I don't know. I mean, yeah, from you're right. From like a purely business model, it doesn't make sense to kill off your clientele.
Yeah,
Yet, I
why would
mean,
you want to?
there have been businesses that have been trying to kill off their clientele for years. I mean, look at the tobacco industry.
And that's been working.
Yeah,
So, I
yeah.
mean, maybe there is an argument to it, I guess. Yeah, that's a good comparison. It just, I think it speaks a lot to where we are in society, that even with all these dangers, people are still going to drugs, looking for either the escape or for the help or to just take a breather from whatever circumstance there is. They still want the drugs.
hmm It is. I mean,
That's like a cry for help.
it is. It is, and it's
Cry for help. I should phrase it. Cry for help if you're struggling and it's a detriment to your life. Because some people can do drugs and
yeah.
they're doctors or they're lawyers or they're
Well,
journalists.
and I mean, that's a huge thing with mental health in general, right? Is for the most part in with the exception of paraphilias, which are a lot of sexually related disorders, most of the diagnostics in the DSM, which is kind of the mental health, dictionary for diagnoses, uh, have a little stipulation that it has to be causing impairment. There has to be a dysfunction to it, right? I mean, if I feel sad one day, that doesn't mean I have clinical depression. It just means I felt sad one day. If that sadness lingers and then it turns to the point where I'm missing work because I'm not getting out of bed in the morning, there's impairment, right? Now it becomes a disorder. Um, the paraphilias are a little different because then they also include if it's causing other people, impinging on their rights, then it also is a disorder. Um, but with substances, yeah, I mean there are folks who can drink, there are folks that can use cannabis, and yeah, it doesn't affect them. You know, I think that for a lot of folks, when you start seeking, heavier and heavier things, maybe it's not affecting your work life, or maybe it's not affecting your social life, but there's a reason you're seeking that to some degree, right? There's some discomfort somewhere that you're seeking that escapism. And I would theorize that, while maybe it's not a visible thing that we can like, point at and say, oh, that's the problem. Um, there's still a component of it there.
And you think that holds true in most cases of drug use? Even if your
Eh,
life is going pretty well and everything seems like it's good, there's
I mean,
something
how
eating
many
at
of
you
us, everything seems like it's good,
on the
right? On
outside.
the outside, right? And I mean, that's like, you bring the whole social media aspect into it, and we're all trying to present like we're doing well, right? Everyone's, it's not it's not as popular to post, oh, my life sucks and this is what's going on. And,
People still do
people
that.
still do
People
that,
still do
and
that.
they get some attention for it. But, for the most part, there seems to be a real competition to, what kind of vacation photos can I Photoshop myself into? And, how can I present things as going well? And even the way we speak, right? I mean, when I walked into the studio and, you said, hey, how's it going? And I said, great. And, and then I asked the same you and you said, great. And, you know, either of us could have had a really garbage day not 40 minutes ago. But our base interaction isn't necessarily going to communicate that. We're not just going to go and disclose all of that. We're going to kind of smooth it over and say, yeah, we're doing all right, doing all right. um and I think that's a societal component, especially in the US, but I don't know that that's not foreign in other societies as well. That desire to make things look like they're going okay, and so I think for a lot of folks, they could be doing substances and behind the curtain, so to speak, and life looks good on the outside, but they're covering something up that's uncomfortable, whether it's a childhood trauma or insecurity around themselves, or maybe they don't think they're doing well, and maybe so they're compensating with that, but their perception of how well they're doing is skewed in some fashion. I mean, there's all sorts of reasons.
There is that desire to keep the public face clean in a sense that
Yeah,
you want to outwardly present that everything is going well all the time. And then whatever is troubling you, whatever problems you're going through, you need to internalize that and work through that on your own.
right.
I've had conversations on here and we've talked about that. That's almost my entire ethos is that you, whatever you're going through, you need to figure it out on your own because it's your problem. You shouldn't be plaguing other people with your woes or whatever's going on because at the end of the day, the only person that's going to fix it is you. So kind of white knuckle
Yeah.
your way through life and just deal with it, which is you could argue is not a healthy approach to
Oh,
solving
absolutely.
problems.
And I mean, I think there's balance, right? I mean, there's the flip end of that, which is that, people don't even take personal accountability for doing what they need to do. And so I think, I mean, it's all about balance, right? This like toxic masculinity, component, or pull yourself up by your bootstraps, and you
Again,
just
that's
got
like
to
my favorite
figure it out, right?
ethos.
And that's not functional in a lot of situations, because there are times when we need to bank on others, right? I mean, whether that's financially, whether that's no 9-year-old is pulling themselves up by their bootstraps, right? I mean, not successfully or well, or in a comfortable state that's not traumatic anyway. And so that doesn't work, even emotionally. I mean, sometimes we need people to talk to, and when we keep that stuff bottled up, it gets out in some fashion. I mean, whether that's anger outbursts, or whether that's drinking, or whether that's some other substance use or poor habit. I mean, a lot of this stuff gets out at some point. And we I think the more that we accept that we are social beings, and we need to engage in community to some degree, uh I think the better we end up doing, and the better our mental health is overall.
Well, and the idea that anybody gets through life on their own is
Yeah,
crazy. You need a support network.
right.
You need people in your life. You need to engage socially. I mean, I think they've done studies where being isolated is just as bad for your health as like drinking alcohol or
Oh,
doing these other
absolutely.
things.
Yeah.
You need to be social.
Yeah, I mean, it can be linked to cognitive decline, it can be linked to all sorts of stuff. And you see that too when you look at pathologies of mental health, right? Different types of mental health across countries. There are, mm, take like South Korea, markedly more family oriented and collectivist country, right? things are done for the family, things are done for the culture, for the country, and there's much less individualism in those societies. And so when you look at the mental health issues that they have, it's very different and things present differently and for different reasons than we do here in the US, which is a very individualistic society, right? Everybody's unique, they're their own special person. We do things for ourselves a lot of time for, self improvement. We don't necessarily go for family improvement all the time. Not that some people don't, right? But it tends to be more individualistic, and as a result we see different types of mental health issues that present differently across cultures, which is I think telling to why maybe we have some issues here in America, and that we don't engage with family, we don't have such a social network, or maybe we do have that social network, but it's not a close social network. It's one that we're putting that facade up, we're saying we're fine when we're
Well,
not.
well, and take COVID for example. When you were
Yeah,
forced to be alone,
exactly.
I, what was the impact of that on mental health and on drug abuse and the homeless? I mean, I would imagine there would have been some increase across the board,
I
right?
I don't think we know the full extent yet, but I know it's bad. Right? I mean, we saw suicide rates go up. We saw as we discussed earlier, opioid overdose rates go up, and deaths of that go up. Um, I think there's more mental health issues now than before. I haven't seen any statistics, but anecdotally, the crises seem to be more frequent and more intense. Um, and I don't think we're in a position, especially in, I mean, the state of California, at least right now. I mean, it's expected that by 2028 will be, there's a big study, I believe, out of San Diego that was looking at this, and something like by 2028, we will be like 20% understaffed for need versus uh, like the ability, like the amount of professionals in the industry to actually provide. And so there needs to be a huge push on like getting people into the mental health field and educated and get their degrees and practice and experience, because in the next 5 to 10 years we're going to be in a situation where we have more demand and less people to provide services.
That's not comforting, right? Do you think that that is currently the biggest hangup is the staffing? Because you always hear that the problem is getting money thrown at it. So is it just a poor allocation of those resources? Is it we're not doing enough, kind of like you pointed out, that we're not intervening enough early enough? So we constantly have to buy band-aids because that's our only tool right now. And so it doesn't really do anything effective that you can see on paper because it's at the bottom end of the chain.
Yeah, I think some combination of all of that. We're definitely, there isn't enough prevention. I remember I read a study back in grad school that showed on a 10-year period, every dollar that was invested in preventative measures actually ended up saving about, they estimated $7 over a 10-year period, right? So while that preventative measure may have been more costly up front, say you have some massive, countywide program, it's going to cost $40 million up front, but it's going to give a lot of preventative care. Theoretically, that would save, you know, 280 million down the road in the next 10 years, according to this study, right? If their projections are accurate. Um, so I don't think that we have enough preventative uh, care. We look at trauma and like the ACEs study that shows, there are 10 factors that eh, when you have four or more of them checked off in early childhood, your chances of having mental health issues and physical health issues skyrockets. Um, and so, you know, there needs to be treatment that is geared towards, and interventions that are geared towards stopping some of those things from happening, whether that's through education, whether that's through, like child welfare services that monitors for abuse, right? I mean, that's why they exist, because we know that when, kids are abused or neglected, they have poorer outcomes later in life. And so, not only is that the humane thing to do, but it's effectively also a cost saving measure, because when, we reduce trauma in childhood, we actually reduce cost of mental health issues later, and physical health issues. So, I think that's a piece of it. I also think that, mental health with the stigma that it has, it's just not the popular field to be in. I think part of that too is that there's just not, uh, we don't understand the brain completely. It's kind of the last organ of the body that like we don't have a great grasp of. We haven't mapped it, right? There's way too many neurons and connections to map. Um, you know, we're getting better about genetics, so we kind of get that. But the brain is definitely still has some mysteries, right, as to how things change. We also don't know how to really medicate it well. When you think about it, when we talk about other meds, there's stuff that can be very targeted. Mental health medications, when you add a medication, you're bathing the whole brain in it, right? So mechanisms are of effect. I mean, we have a decent understanding of how it works, but it's not dialed in. Like we can't say it's a guarantee that, oh, when you add this med, then this part of the brain changes and does this, and then this happens. Because you're also affecting every other part of the brain with that medication. Um, and so I think because it's not totally well understood or as well understood as other fields of medicine, and because there's so much stigma, folks don't go into it as much. It also is a field where you need an incredible amount of patience with people. I mean, you know, if you think about it, most of us, when we see someone who's acting out or having some sort of mental health symptoms or, reaction to a substance that they used walking down the street, I think a lot of folks look at that and, if you're not working and you're not, meant to be working with that, you look at that and you think, maybe I'm going to cross the street right now. Right. That's a pretty standard response. And so, you know, it, why does that happen? Why do we think that way? Well, we think that way because we don't necessarily understand that that person might be sick, right? I mean, that's not where people's minds go to. No, not as many people see someone doing that and think, oh, they're suffering right now, or oh, that's a crisis. If we see someone who has their leg broken and they're laying on the ground and then their leg is crooked and not bent right, we're going to call an ambulance. A lot of times when folks are having mental health crises and in the community, unless they're causing a disturbance and it's getting to the point where people are calling 911, uh, people just avoid it. And so that stigma is real, and it's real in people going into the field of healthcare too. We're graduating less psychiatrists now than we were 40, 50 years ago. We don't have enough therapists in the area. We don't have enough therapists statewide. uh, it, care for like lower level professional classes, so like mental health workers, right, which is kind of like a mental health version of like a certified nursing assistant. We don't have enough folks filling those positions. I mean, that was the in my time at Semper Virens, I mean, that was probably the most difficult position to fill consistently, was the mental health worker position, just because it's an entry level, a more entry level position for that type of work, and it's rough work. And the pay isn't the best. I mean, it's not the worst, but it's not the best. And it's a situation where uh, when people look at that and they think, okay, I can go and I can work and make this much, and I can work really hard, be at risk of getting hit, have to deal with folks who are incredibly sick
And
and
unpredictable.
unpredictable, and or maybe I can be paid a little bit less or have a little less benefits and go work at Winco or go work at the mall. um I mean, it makes it so that you have a difficult position to fill, and it's incredibly important. I mean, the mental health worker staff, like a lot of CNAs, are the ones who are having a lot of the primary contact with those people, because they're the ones who are doing a lot of the work, right? They're having the contacts with the patients, and the nurses or the clinicians are checking in with them intermittently, but it's very goal directed, right? It's very, I'm coming to you, we're going to do this thing, and then I'm going to step back. And so it's a job that's very much needed. We don't have enough case managers. Case management's the same thing. I mean, these are the folks who are doing the legwork. I mean, it's like case managers for care. I mean, when I go out and see a client, it's risen to a crisis situation, and I go out, I do my assessment, we create a plan, and then I walk away. And then that case manager has to then go and fulfill that plan, right? They take that plan and run with it, and they're the one who's then spending the next maybe anywhere from a half hour to a couple hours with that client, going from point A to point B to point C to point D, trying to get that safety plan activated. And that requires a lot of patience for someone who's, to work with someone who's really sick, who's having those types of symptoms, and to be able to stick with it and do that. It's exhausting.
What made you want to go into this field and focus on mental health? What was the desire to do that?
Well, I didn't initially.
Because you're a marriage and family
I
therapist,
am.
right? That's
Yep.
your background?
Yep. Yeah. So my license is a marriage and family therapist. I graduated here at Humboldt. Um, initially I went to San Francisco State and I did graphics design,
Kind of a
and
pivot.
a little bit, and had an epiphany that I didn't. I looked at like the other 400 people who were doing graphics design at San Francisco State as a freshman, and thinking, maybe not the best, outlook.